Okay, it's time to get started. This is going to be module number 7. This is the Haynes method, neuromuscular dry needling. This is our hybrid dry needling course for those taking Lab 1 and Lab 2. This will also lead to certification in dry needling. So here we are at the advanced lumbar and the SI joint. And so let's just kind of get started here. The contents of what we'll cover. We'll look at some supporting evidence, our clinical decision making. We'll look at some surface anatomy, three-dimensional anatomy, and then we'll look at our needle placement and demonstration of the dry needling techniques for the lumbosacral muscles, the pelvic rotator cuff muscles, the tendons and ligaments of the pelvic rotator cuff, and then some perineural protocols and our regional diagnosis specific protocols. So in our supporting evidence, we'll start. First is a study by Copenhaver. This was back in 2015. The objective to explore for associations between demographic, patient history, and physical examination variables and short-term improvement in self-reported disability of following dry needling therapy performed on individuals with low back pain. And they had their participants were people with mechanical low back pain. And the conclusion was that increased low back pain with the multifidus lift test was the strongest predictor of improved disability after dry needling, suggesting that the finding of pain during muscle contraction should be studied in future dry needling studies. Another by Puntadura, again here in 2017, their purpose to investigate changes in resting or contraction thickness of the transverses abdominis muscle after dry needling of the lumbar multifidus in asymptomatic participants. They used healthy individuals who had not experienced low back pain in the previous 6 months, and they were randomly assigned to receive dry needling to the lumbar multifidus or a sham dry needling intervention. In their conclusion, dry needling to the lumbar multifidus was accompanied by decreased resting thickness and an increased contraction thickness of the transversus abdominis in these asymptomatic participants. Another here by Hugh from 2018. Their background, their objective was to evaluate the efficacy and safety of dry needling for treating low back pain. They looked at 16 randomized control trials, and what their conclusion was, compared with acupuncture and sham needling, dry needling was definitely more effective for alleviating pain and disability at post-intervention in low back pain, while its effectiveness in pain and disability at follow-up was equal to acupuncture. Future randomized controlled trials with rigorous methodologies are required to confirm their findings. So we're still early in our research in how effective dry needling is. We all as clinicians have lots of anecdotal proof, but we just need to see more research targeting specific diagnoses, specific muscles, in order to build that body of evidence a little bit further. So on our clinical decision making, we're going to look at our 3KS, our three-dimensional kinetic screen. Again, we're going to have a look at the cervical, thoracic, and lumbar spines. We have, as in previous, you've seen my demonstration of this. So for time's sake and for brevity, I'm not going to repeat that. However, it will be, again, you can watch the same video in previous modules. It should be the same one for the thoracic. But since we're here, let's just kind of quickly go through that. Okay. So what we will look at, again, we're going to have our cervical linear motion, and I'm going to kind of advance here. Just a unidirectional movement. We'll add a three-dimensional approach by adding diagonal rotation. We'll look at several repetitions on each side. So we'll move to the opposite side. And what we're looking for, again, in each of these repeated movements is quality of movement, quantity of movement, and if there is any asymmetry in movements, or does one particular movement seem to cause pain in one direction or at particular arc of movement. Again, a nice three-dimensional functional screen to rule out or to rule in areas of dysfunction. So then we have the trunk. Again, just looking at them from a lateral standpoint. And then for the trunk rotation, similar. And then we'll have our lumbar, our linear motion, just pure flexion to pure extension. Likewise, we'll look at our lumbar diagonal rotation. Again, adding a third dimension into that movement piece. Again, looking for quality, quantity of movement, and if there's any movement abnormalities, any asymmetries, or any pain that can be provoked in any particular movement. All right, so for our lumbosacral muscles, a lot of this we will have already covered in our introductory material, but we'll go through it again. Interspinalis, longissimus, iliocostalis, lumborum. We'll look at the multifidus, the Psis. We'll also look at quadratus lumborum, iliacus, psoas major, and then a little bit higher, the serratus posterior inferior. As in the previous modules, all of this information is going to be available. I'm not going to sit here and read all of this information to you because our ultimate goal is to get down to three-dimensional video demonstration of this. So this information, again, is available to you to review in our slides. But let's get on to our three-dimensional anatomy here. Let's take a look at our lumbosacral musculature. Let's just start superficial and then work our way deep. First, we'll take a look here at our serratus posterior inferior, and talking about our three-dimensional anatomy, any relevant surface anatomy. So here our origin is going to be spinous process of T11 to L2. It inserts into the external surface of the 9th to 12th ribs, and its action is to depress the ribs at their costovertebral joints. Innervation, anterior rami of the 9th to 12th thoracic nerves. These are, and I'm going to zoom in here, going to be fairly superficial strap-like muscles in this area. So as we are dry needling into the multifidus longissimus through here, we know we're going to get through that muscle as we do that. So here we are at 12, so 11, 12, 1, 2. In that area, we will needle through that. If we feel the need to specify these particular muscles, then we can just drop off. And again, it's superficial, 2, 3 centimeters at most, anterior to posterior direction, slightly midline. So serratus posterior inferior. Let's go ahead and hide those on both sides. And then let's take a look at, again, the longissimus and the iliocostalis lumborum. And a little bit later, we'll talk about the tendons, the epineuroses here of these two tendons as they come down off the ilium onto down. Let me get rid of the sacrotuberous ligament here. Hide that. Okay, so we see that it has a large sacral attachment So anytime we're dealing with that pain, that may be an area we need to look at. We can definitely find our location with surface anatomy through palpation of the iliac crest coming down to the Psis, located here. But again, we've talked about the 3D anatomy of longissimus and the lumbar spine. It is going to sit posterior and superficial to longissimus. So let's pull that away, or superficial to multifidus, I should say. Then iliocostalis will be at that lateral border of the longissimus, and then it's going to travel as far as its terminating or its origin onto the iliac crest, proximal or further away from the Psis. And as you recall, it comes up around the TL junction. Then it starts to make a little bit of a lateral course up towards the medial border of the scapula. And then there are more branches of iliocostalis coming even higher. So iliocostalis, one thing to note is with iliocostalis, when we're talking about, I'm going to make a jump here to the quadratus lumborum. So we're looking at a posterior to anterior view. The lateral border of iliocostalis identifies the medial border of quadratus lumborum. So for dry needling's sake, that is a nice way for us to find that lateral border of iliocostalis. That tells us exactly where our, our location is of QL. So I'll pull this, let my computer catch up, hide that. And so that gives us our location, QL. QL, origin is the posterior half of the iliac crest and the iliolumbar ligament as it's coming from, well, here we are. We'll talk about iliolumbar ligament in a bit when we get to that. But also its insertion inferior border of the 12th rib, and then the transverse processes of the 1st to the 4th lumbar vertebra. Its action is extending. Let me get back to that. Okay, it extends and laterally flexes the trunk, and it stabilizes the 12th rib during inspiration. Innervation is through the anterior rami, 12th thoracic, and 1st to 4th lumbar nerves. So fairly decent sized muscle. We will, when we get to the procedure on dry needling it, I'm going to fade it as we look, and then we can see just forward of that, the psoas major. So when we needle through the QL, we can take a posterior to anterior angle with our needle, and we can actually needle both muscles simultaneously. We'll end up doing it right about this area right here. Nice line between the ilium and L4 will give us a nice location there. The transverse process, say L4. There we go. So that's our QL, and I'm going to hide our QL. I haven't mentioned multifidus. We've covered it several times. Again, deepest layer of muscle with origin on the sacrum itself, very distal and going all the way to C2. So let's go ahead and hide that. Let's turn ventrally and look at, again, we talked about psoas. It is its origin, the transverse processes of L1 to L5, and then the vertebral bodies of T12 to L5. It inserts into the lesser trochanter of the femur. So as it drops through posterior to the inguinal ligament, you can see it has its attachment right there. And so given its course, its action is flexing the thigh at the hip joint. One could also be excused for thinking that it provided some external, some rotation at the hip joint. but flexion is its main objective. Innervation, anterior of the first, second, and third lumbar nerves. The iliacus, let me go ahead and remove psoas. I'll hide that. So iliacus, excuse me, its origin is the iliac crest, superior 2/3 of the iliac fossa, the ala of the sacrum, and the anterior sacroiliac ligaments. Its insertion is also into the lesser trochanter of the femur via the tendon of the psoas major. Again, its action flexing the thigh at the hip joint. Its innervation, femoral nerve, L2 through L3. We'll find when we get to the needling component, a couple of ways we can needle that itself. Actually, several. We can catch it just lateral to the femoral neurovascular bundle onto the neck of the femur itself. We can also catch it from an anterior to posterior here, above the inguinal ligament, or we can also in a side-lying position. See if I can get this guy all the way over. Well, kind of hard. Assuming he's laying on this opposite side, you can push that skin in and needle from a medial to lateral on the medial aspect of the ilium into the iliacus itself. Usually my preferred method is either in this muscle belly right here or just superior into that area. So those are the muscles of the lumbosacral region, 3D anatomy, relevant surface anatomy that we're interested in those muscles, and we'll move on from there. Okay, so as far as our treatment, let's move on to this, and I will just move on to each of the respective muscles. For the lumbar interspinalis, position is again going to be in the prone position. Needle length here is less than 20 millimeters. We definitely don't want to enter that spinal canal. There's no backdrop. We're going to use our fingers to locate the interspinous space between L3 and L4. When dealing with the spine, this will be the only time that you will have a superior needle angulation here with a 15 to 20 degrees anterior superior angulation perpendicular to the skin surface. Caution for depth here, definitely less than 20 millimeters to avoid the spinal canal. Okay, and then for the longissimus and multifidus. In the lumbar spine, for the longissimus and the multifidus, patient is going to be here in the prone position. Needle length will be 40 to 60 millimeters with a backdrop onto the lumbar lamina. We're going to palpate for the spinous process of L4 at the level of the iliac crest. Needle inclination will be 1 finger breadth lateral from the spinous process. It should be a 15 to 20 degree anterior, medial, and caudal angulation in each plane, perpendicular to the skin surface or relative orientation of the vertebra to contact the base of the spinous process on the lamina. Okay, then Iliocostalis. For the iliocostalis in the lumbar spine, the patient again is going to be in the prone position. Needle length is about 30 millimeters and there is no backdrop. What we're going to do is grasp the lateral border of the rector spinae group with a profundus grip. we're going to apply some firm pressure and splay the index and middle finger. Here we're then going to needle 3 to 4 finger breadths lateral to the spinous process of L4 with a 45 to 80 degree medial and a 15 to 20 degree caudal angulation in each plane perpendicular to the skin surface or relative orientation of the vertebra. Okay, then on to the PSIS. For the PSIS, obviously, patient's going to be in the prone position. Needle length here, 3 to 5 centimeters, depending on patient habitus. Backdrop, obviously, is the PSIS. We're going to palpate the vertical length of the PSIS, and we're going to use the needle to needle through the connective tissue and peck on the periosteum, locating 2 to 3 different areas on the PSIS. And then to the quadratus lumborum and psoas major. In a prone position, we're going to treat quadratus lumborum and psoas major. Needle length here will be 3 to 5 centimeters. There's not going to be a backdrop. So we're going to palpate for the lateral border of the lumbar iliocostalis in the mid to upper lumbar region. This will approximate the medial border of QL. Follow its path distally to the iliac crest, then 2 finger breadths lateral along the iliac crest and 2 finger breadths superior to identify the needle insertion point. Angulation will be anterior to posterior, and you will needle through the QL before entering the psoas major. And then Iliacus. So for the iliacus in the sideline position, the needle length is going to be 3 to 5 centimeters here. Backdrop is either going to be none or the internal ilium. Have the patient lay in the sideline with a pillow placed in between the iliac crest and the rib cage on the downside, and have the upside arm held in full abduction over the head. We're going to palpate for the superior aspect of the iliac crest at the sideline apex of the iliac crest. We're going to use a splayed finger technique. We're going to push the skin and the underlying abdominal and oblique musculature medially to hook over the iliac crest. Needle angulation from 1 finger breadths medial to the iliac crest will be cranial to caudal, slightly lateral, directed towards the internal ilium as a backdrop. Caution here definitely to avoid a medial angulation with the needle and the abdominal contents. And then the serratus posterior inferior. For the serratus posterior inferior, patient again is going to be in the prone position. Needle length is going to be 2 to 3 centimeters, and there's no backdrop here. We're going to palpate and identify the spinous processes of T11 to L2, most easily identified by following the 12th rib towards the spine. We're going to needle from lateral to medial, slightly caudal, 2 finger breadths lateral from the spinous process. It is going to be superficial, and there is no backdrop unless including underlying musculature. Okay, so now onto the pelvic rotator cuff muscles. Again, a lot of these we have already covered. We will add just a little bit more to this, but just for review, we're going to come back and go over these. First off, let's come through, again, relevant slides for your information and review, but let's get down to our 3D anatomy. Okay, let's get into the three-dimensional anatomy, relevant surface anatomy of the pelvic rotator cuff. I include the pelvic rotator cuff in the advanced lumbar spine SI joint simply because of the proximity to the lumbar spine. A lot of the pain complaints that we do have a little further distally and then lateral, some of that radiating pain complaint that we get. As you know, we do see some back pain that is just limited to central spine, slightly adjacent, but just as frequently we see radiation into the, say, the SI joint region or laterally, inferiorly down towards the greater trochanter. We may even see some radiating down the lateral aspect, posterior, anterior, into the leg. And that's why I do include these structures here. So we'll start with, again, relevant surface anatomy. Definitely want to be able to identify the iliac crest all the way posterior to the Psis. Laterally, we want to be able to identify the superior aspect of the greater trochanter, and then using surface anatomy, iliac crest, to come across to identify L4. We can drop down to locate L5, and then subsequently the end onto the sacrum. We can use those landmarks to identify. But I will say we also want to be able to identify with this course, this lecture, the tip of the sacrum, the tip of the coccyx, and the lateral border of the sacrum. As we get to certain structures, we're definitely going to need to know and be able to identify those areas. So onto the Gluteus Maximus. We've covered Glute Max and the first of these muscles quite a bit through the introductory piece, but let's cover quickly the Glute Max Origin, the area of the ilium located posterior to its posterior gluteal line, the posterior aspect of the sacrum and the coccyx, and the Sacrotuberous Ligament. It's been removed here normally. Okay, there it is. The Sacrotuberous, I was thinking Sacrospinous, but Sacrotuberous Ligament there. It inserts the tubercle of the iliotibial tract on the tibia via the iliotibial tract, and then the gluteal tuberosity on the femur. Its action extends, laterally rotates, and abducts the thigh at the hip joint, innervated by inferior gluteal nerve L5 to S2. So that one is, let's hide that. That'll bring us to, let's do TFL and the IT band first, get it out of the way. So TFL, the muscle, attaches to the iliotibial band. IT band is it's running distally to its tibial insertion on the tibia, but its origin, the anterior superior iliac spine and the anterior 1/3 of the outer lip of the iliac crest. So it is easy to find if there is some sort of a lateral tension dysfunction going on at the greater trochanter. You will be able to palpate that band of tissue coming up. That'll be the posterior border of the iliotibial tract, with TFL sitting slightly anterior. It inserts, again, the tubercle of the iliotibial tract on the tibia via the iliotibial tract. Its action is assisting in medial rotation, abduction, and flexion of the thigh at the hip joint. With its innervation, the superior gluteal nerve L4, L5S1. And so let's get that removed so that we can then look at glute med and then glute min. So glute med, now let me undo that. All right, get out of that. So with your 3D application that you use, that you should be using, it does take a little finesse in learning how all the intricacies of the system work. But anyway, glute med, Bring that back up here. Origin, the area of the ilium located between the anterior and posterior gluteal lines. It inserts into the lateral aspect of the greater trochanter of the femur. It's always curious to note the glute med inserts more on the posterior aspect of that greater trochanter, while as glute min we see attaches more anterior. So its action medially rotating and abducting the thigh at the hip joint. This one is innervated by the superior gluteal nerve L5-S1. We'll hide it, get us down to glute min. And when we're finished, I'll demonstrate something on the glutes. So glute min, bring that back up, please. Thank you. Origin, the area of the ilium located between the anterior and inferior gluteal lines. Inserts into the anterolateral aspect of the greater trochanter of the femur. Again, sits more anterior. Its action is it immediately rotates and abducts the thigh at the hip joint. And its innervation is superior gluteal nerve L5-S1. So in dry needling, any of this lateral hip joint, when we get to it, you'll see that there are several needle placements that we do for this problem. One of them you're going to find for Gluteus Maximus, we're going to find we're going to take a line from the greater troch to the Psis, and at a midpoint, we're going to drop a needle right there. Well, that happens to be the convergence of both the Gluteus Maximus, Gluteus Medius, and Gluteus Minimus, and that tends to be a hot spot, a very tender location. We get a lot of good benefit from the needle placement right in this area. But let's go ahead and move medius out. Let's look at Piriformis. I'm sorry, Minimus. Now let's look at Piriformis. Its origin is the pelvic surface of the sacrum and the Sacrotuberous Ligament. And so this is the Sacrotuberous Ligament coming from the ischium all the way to the sacrum and then further up to the Psis. And so it does have an attachment there. Its insertion is the superior border of the greater trochanter of the femur. And so you can tell it sits more medial on that lip of the greater trochanter. And so its action is it laterally rotates and transversely abducts the thigh at the hip joint, and it's innervated by the nerve to Piriformis, S1, S2. So there'll be two needle locations here. One are traditional that we have already gone through in the first lab, needling out here. As we get more advanced state, we'll see a method where we can dry needle off into the muscle belly itself a little bit right here. Have to be cautious here because of the area of travel of the sciatic nerve as it's coming right here. And so we'll learn to adjust our depth for needling to simply needle into the piriformis. All right, I'll hide that. And then the next muscle in the chain of the rotators. First is superior gumbalis. Its origin is on the ischial spine. So we have the spine right here that creates the foramen above and below the sciatic foramen. And so its origin, ischial spine, insertion in the medial aspect of the greater trochanter of the femur. It will sit just inferior to where piriformis was. Its action is laterally rotating and transversely abducting the thigh at the hip joint. Its innervation is nerve to obturator internus L5 to S2. So I'm just going to fade that and we'll drop down to obturator externus. Sorry, obturator internus. Here the origin is the internal surface of the obturator membrane and the adjacent bones. For our purposes here, how we needle all these rotators will be limited to this area right here. When we get to the advanced pelvic floor, we will discuss how to needle into the muscle belly itself right here. But it's, again, origin, internal surface of the obturator membrane and the adjacent bones. It inserts into the medial aspect of the greater trochanter of the femur. So as you can tell, we're just making our way down this line on the femur. Its action laterally rotates and transversely abducts the thigh at the hip joint. Its innervation again is the nerve to the obturator internus 5-1. So we'll fade there, and then we'll drop to the inferior gemellus. Here we are going to look at, let's see, origin again, so directly comes onto the ischial tuberosity. We'll see that for that and for quadratus femoris. It inserts the medial, medial aspect, the greater trochanter of the femur. It's actually, again, laterally rotating, transversely abducting the thigh at the hip joint, nerve to quadratus femoris 5-1. So we're gonna skip one of the muscles here and drop. Let me put that back and just fade it. So we'll get to now quadratus femoris. We'll do this first. The quadratus femoris origin, the lateral margin of the ischial tuberosity. It is inserting into the quadrate tubercle of the femur. Its action is laterally rotating the thigh at the hip joint, and it's innervated by the nerve to quadratus femoris, or L5S1. So fairly broad muscle. When we needle, that will be our terminal needle placement or location as we redirect. I'm going to hide that so that we can now see obturator externus. So internus sat right here on the obturator foramen. For obturator externus, it's going to sit on the anterior aspect. So here, and I'm going to come back to our posterior view here. So here our origin is the external surface of the obturator membrane and the adjacent bones. It inserts in the trochanteric fossa of the femur. Again, a lot of attachment right here. Its action laterally rotating the thigh at the hip joint, and it's innervated by posterior branch of the obturator nerve L3, L4. So those are the rotators of the hip, the external small rotators. Again, we're going to needle those specifically for this area with one needle with a redirection approach. We will move on to, let me reorient here, and I'm going to take some of these ligaments out. So we'll get rid of Sacrotuberous. Sacrospinous is already gone. All right, so actually let me get rid of that as well. All right, so the next one we'll look at will be, come on. All right, Coccygeus. Here its origin is the ischial spine. Okay, I get origin insertion backward. So the ischial spine will be its origin right here. Again, that's that ligament, spinous, sacrospinous ligament, gives us our border for creating the ischial, sciatic foramen. But the Coccygeus attaches or has an origin here, and its insertion is into the enteral aspects of the sacrum and the coccyx. So it has attachment on both of the locations here. So as we move through this, and we'll look at the levator ani in a moment, we see the tip of the coccyx, we have levator ani or Iliocostalius. Then we move up half of the coccyx into the lower half of the sacrum, and there we have the Coccygeus. And then that superior piece, then we have the Piriformis, all in a nice line down the sacrum to the tip of the coccyx. Coccygeal action provides structural support to the adjacent pelvic structures. Its innervation is the anterior rami of the fourth and fifth sacral nerves. More specifically, it assists in pulling the coccyx forward to help control during defecation. So we'll move from there, and then we'll identify the Iliocostalius, or one of the pieces of the levator ani. Its origin, the ischial spine, again right here. Then there's a tendinous arch of the levator ani. We have a hard time seeing it there. There it is. So it also across this tendinous arch right there. And then its insertion will be into the coccyx and the iliococcygeal raphe and the anococcygeal ligament. Our biggest area where we're concerned is in the coccyx, because we can needle into that. We'll demonstrate how to provide a proper depth so we get our good response with that tissue. And those are the muscles. So similar, its function action is pulling the coccyx forward, assisting in defecation. And it plays a key role in control of the pelvic floor as far as pain, incontinence, and so forth. So those are the muscles of the pelvic rotator cuff. Okay, so let's move into treatment, and we'll just calm down and just dive right in. So first will be Gluteus Maximus. For the Gluteus Maximus, the patient is going to be in the prone position. Needle length here will be 40 to 60 plus millimeters. The backdrop is going to be on the ilium. We're going to locate a midpoint between the Psis and the superior aspect of the greater trochanter. We're going to needle posterior to anterior with relative orientation to the ilium. Use the ilium as a bony backdrop. Caution here for the sciatic nerve. Proper angulation of the needle perpendicular to the ilium will place the needle superior to the sciatic nerve.
And now we're good.
All right. Okay, we'll go from max to medius. For the gluteus medius, the patient is going to be in the prone position. Needle length here is going to be 40 to 60 millimeters. The backdrop is going to be onto the ilium. We're going to palpate for the iliotibial band superior to the greater trochanter to the iliac crest. We're going to move 3 finger breadths posterior on the iliac crest and then insert the needle 2 to 4 finger breadths inferior from the iliac crest into the muscle with an angulation into the muscle perpendicular to and using the ilium as a backdrop. Okay, from there, then we'll move on to glute min. For the gluteus minimus, patient again is going to be in the prone position. Needle length is 40 to 60 millimeters, and the backdrop is going to be onto the iliofemoral ligament. We're going to palpate the apex of the greater trochanter and the iliac crest. We should palpate the IT band along this path. And we're going to insert a needle at a midpoint between the iliac crest and the trochanteric apex in a lateral to medial direction using the iliofemoral ligament as a backdrop. And then on to the tensor fasciolata, or the TFL. For the tensor fasciolata, or the TFL, patient again is in the prone position. Needle length here is 30 to 40 millimeters, and there's no backdrop. We'll palpate the apex of the greater trochanter and the iliac crest. We should palpate the IT band along this path. We'll grasp the anterior aspect of the TFL with the fingers and the posterior aspect of the IT band with the thumb. At the midpoint between the 2 bony landmarks, we'll insert a needle and advance posterior to anterior, medial to slightly lateral towards the table, using your fingers as a backdrop to determine adequate depth. Okay, then Piriformis. For the Piriformis, the patient again will be in the prone position. Needle length can be 30 to 50 millimeters. The backdrop here will be the ischiofemoral ligament. For the lateral attachment, we'll palpate for the superior aspect of the greater trochanter and locate its medial most aspect. Needle insertion point is 2 finger breadths medial and 1 finger breadth superior, posterior to anterior, using the ischiofemoral ligament as a backdrop. And when we get into lab 2, we'll demonstrate how to needle off of the sacrum from the medial part of piriformis to land just off of that lateral sacral border in order to needle from the medial aspect as well. I've personally found the lateral approach does just fine, but in some cases we may want to get a little bit more of that muscle belly and catch it on the medial aspect as well. Okay, and then we will go through all of the hip rotators. For the superior gemellus, the obturator internus, inferior gemellus, obturator externus, and quadratus femoris. We're going to treat this as a single unit. We're going to be in the prone position. Needle length here could be 30 to 50 millimeters, and our backdrop is going to be onto the femoral neck. These muscles are most frequently needled as a group using a redirection method. We're going to palpate the superior aspect of the greater trach and then locate its medial most aspect. We're going to needle insertion point at 2 finger breadths medial and 1 finger breadth to 4 finger breadths inferior, PA, using the femoral neck as a backdrop. All right, so from there we'll move on to the Coccygeus. Again, the method for Coccygeus and Iliocostalius or levator ani is going to be the same approach that we take for the medial border of piriformis. But first let's look at Coccygeus. For the Coccygeus, the patient position will be prone. Knee length here will be 2 up to 3 centimeters, and there will be no backdrop. Precautions here for the 5th sacral nerve, the coccygeal plexus, the nerve to the levator ani muscle, and the rectum. For the procedure, we're going to palpate the lateral border of the sacrum, and then the distal aspect and the sacral cornu or the sacral horns. We're going to insert a needle posterior to anterior, slightly lateral to where you just palpated the sacral horn to determine needle depth at the sacrococcygeal junction. Then we'll move 1 finger breadth laterally until you feel the drop off of the lateral sacral border, and we'll needle in a posterior to anterior angulation slightly lateral, no further than 1 to 1.5 centimeters deeper than your test needle to treat the coccygeus and avoid the deeper rectal contents. So the easiest way to determine that depth is when you do use your test needle, just be aware of the amount of the needle that's remaining exposed as you find the depth on the sacrum, and then as you move laterally, then you know that you can advance another centimeter to 1.5 centimeters in depth to provide safety for those internal rectal contents. And similar for the Iliocostalius portion of the levator ani. For the levator ani, specifically the Iliocostalius, position is going to be prone. The needle length here will be 2 to 3 centimeters, and there is no backdrop. Precautions here: the 5th sacral nerve, the coccygeal plexus, and then the nerve to levator ani muscle and the rectum. For the procedure, we'll palpate for the lateral border of the sacrum, and then the distal aspect and the sacral cornu or the sacral horns, and the distal aspect of the coccyx. The Iliocostalius attaches to the distal half of the coccyx. We'll insert a needle posterior to anterior, slightly lateral to where you palpated the coccyx to determine the needle length at this needle depth at this location. Then we'll move 1 finger breadth lateral and needle in a posterior to anterior angulation, slightly lateral, no further than 1 to 1.5 centimeters deeper than your test needle to treat the Iliocostalius and avoid the deeper rectal contents. All right, now let's move on to the pelvic rotator cuff tendons and ligaments, and quite a few that we have to look at here. So let's move on again. All this information available for you for your review. Let's go straight into our 3D anatomy of this. Okay, let's look at the ligaments that we deal with the lumbosacral spine. We have so we have interspinous ligaments in the lumbar spine that we can needle. We don't typically attribute those to much pathology, and because they are midline, really kind of hard to needle into them. However, if we are, and we've talked about the interspinalis that we can needle those. There they do sit in between each of the spinous processes. I don't really include that as part of the system. However, we will needle into them if we do needle into interspinalis. So worth mentioning there. Let's talk, and let's start with. Let's see, where should we start? Let's start on the anterior aspect. I do include this because there is some component here. We'll probably deal with this more with the hip, but we do have a piece that we deal with on the inguinal ligament. We do have muscles attached there, and there's some nerve issues that we'll deal with, but it is, let's see here, from the ASIS over to the near the pubis itself. Let's see, we also have here the interpubic disc. Get rid of that. Sitting in between. A lot of people do tend to have pain at the interpubic disc for a variety of reasons, and definitely it is a needleable connective tissue. So in the anterior aspect, that's pretty well what we'll look at. We'll move more posteriorly, and let's hit first the iliolumbar ligament. Frequently see people with pain in this vicinity. The iliolumbar ligament itself is fairly large. The area that we can gain access to on the posterior aspect between this transverse process of L5 and L4, and where it comes over and attaches onto the anterior surface of the ilium there, we can gain access to that. So that is one to consider. On the posterior aspect, the sacrotuberous ligament, there are places along this ligament where we can definitely do some needling. Typically, we'll do it at the Psis. We'll do it more near the sacrum, or we can do it near the ischial tuberosity. Could be done anywhere along that line, but those 3 attachment points, probably the location where we'd have more of our issue. On the left side of the pelvis here, we see the sacrotuberous ligament has been removed. Beneath that, we will find the interosseous sacroiliac ligament. As we can see, it does a fairly good job of providing a little bit more support here for the ilium over to the sacrum, so that connective piece that we see for the SI joint. I will remove that, and then we'll get a little bit deeper into the posterior sacroiliac ligament. And as you can tell, it covers, let me come forward, well, it's going to sit deep there. So in this sacroiliac region, probably a really strong on the posterior side support mechanism for that. So we had the other ligament structure, and then we have this. So a lot of ligamentous support right there. We do take advantage of that. We do needle into ligamentous structure. So if we are having some issues in that SI joint, we will find that we want to needle inferiorly, and now in this case laterally, to get into all of this ligamentous structure there. I'm going to go ahead and hide that one so we can get deep into that SI joint, and that's kind of our target is right there. We move, let's come on down a little bit. So here we have the sacrospinous ligament, sits just posterior or more superficial to the coccygeus muscle, which was just anterior to this. So that if we're going to needle into the sacrospinous ligament, we'll be needling into the coccygeus as well. We also have in this area the supraspinous ligament, again, just a continuation of the ligaments running between the spinous process, or the superficial part of the spinous process. How often is that clinically relevant? Probably not very often, but worth having in your tool belt in case. Deep to that is going to be the interspinous ligaments. Those will actually travel out a little bit laterally from that. To provide a little bit of some support there. And let's see, I think that is all of the ligamentous structures here. I do want to bring up, we've got all of those. I want to bring up one more grouping of ligaments here. Let's see, let's do it right here. And that is the tendons of the iliocostalis and the longissimus. So as we get low down into the lumbar spine, we do tend to find people having a lot of pain in this area. And as you can tell, this muscle has started to converge from true contractile element to more a tendinous grouping, and very frequently these muscles here, as you can tell, that's also the location of the thoracolumbar fascia. So all of these tissues are starting to plane together and merge, and truly these are merging in this area, so it's hard to differentiate one versus the other. So like to treat those almost as a single unit. A lot of times we can needle directly into that, onto the sacrum in this area. So good piece to know on that. And those are our tendons and ligaments of the lumbosacral spine. Okay, there. Okay, so let's move into our treatment. We'll start with the inguinal ligament. For the inguinal ligament, position here is going to be supine with a needle length of 1.5 centimeters, and there is no backdrop. The precautions here, the anterior cutaneous branch of the iliohypogastric nerve, the lateral femoral cutaneous nerve, the ilioinguinal nerve, superficial circumflex artery and vein, and then given the location, any of the lower abdominal contents. So the procedure, we're going to palpate the ASIS, and then the origin of the sartorius as the subject lifts the leg off the table. Needle location is going to be 1 finger breadth medial from the sartorius along the line of the inguinal ligament. So with this attachment, we'll needle for inguinal ligament right in this area. So if you will, pull your foot back towards you just a little. The whole slide back to me. Oh. There, and relax. Okay, next will be the interpubic disc. I have had patients with pain there at the interpubic disc, just mechanical issues. The area gets inflamed, and absolutely do see benefit with needling there. For the interpubic disc at the pubic symphysis, the patient will be in the supine position. This will be a shallow needle stick. It'll be 1.5 centimeters, and there is no bag drop. For the procedure, we're going to palpate for the space between the pubic bones, and we're going to move caudally 1 finger breadth to identify the needle location. The angulation here will be anterior to posterior with a slight caudal angulation with no bag drop. Okay. So for the Sacrotuberous ligament, we have 3 locations for potential needling there. For the Sacrotuberous ligament, we'll have 3 needling locations of this broad reaching ligament. First at the Psis, the needle length here is going to be 3 to 4 centimeters with a backdrop down to the lateral sacral border, precaution of the medial colonial nerve. For the procedure, we're going to palpate for the Psis and the sacral horns and the sacrococcygeal junction. We're going to draw a line connecting those two, and we'll bisect the line in half, and then needle placement will be midline in the cranial half and a P to A angulation with a backdrop of the sacrum. At the sacrococcygeal junction, here needle length will be 2 centimeters, and there's going to be either no backdrop or very similar to the sacrospinous ligament. Precautions here for the medial colonial nerves. The procedure will palpate for the sacral horns at the sacrococcygeal junction. Needle placement is going to be 1 finger breadth lateral from that sacral horn in a posterior to anterior angulation with no backdrop or the sacrospinous ligament. It's a very superficial structure with the rectum anteriorly. And then thirdly, the ischial tuberosity. The needle length here is 3 to 4 centimeters again. Backdrop is the medial surface of the ischium. Precautions for the posterior femoral cutaneous nerve, the inferior rectal artery and vein. We're going to palpate for the inferior most aspect of the ischial tuberosity. Sacrotuberous ligament attaches to the medial aspect of the ischium. So needle placement will be at the medial border of the ischium, posterior to anterior with a slight lateral angulation with a backdrop onto the ischium. Obviously demonstrated here. Very important to be comfortable with and very aware of what you're palpating so that you actually end up needling what it is you're trying to target. Okay, from there we'll move on to the tendons or the anastomosis of the Iliocostalis and the longissimus. For the tendons of the Iliocostalis and the longissimus, their attachment is onto the dorsal and the posterolateral surface of the sacrum, the iliac crest. Position for treatment is going to be prone. Needle length will be approximately 3 centimeters. Backdrop here is either none or the sacrum for the longissimus. Precautions for the medial and the superior colonial nerves. For the treatment procedure, we're going to palpate for the PSIS. For the Iliocostalis tendon, we'll insert the needle 2 finger breadths cranial. For the longissimus tendon, we'll insert the needle at the midpoint between the PSIS and the S2 spinous process. Needle angulation will be posterior to anterior with no backdrop, or the sacrum for the longissimus. So first for Iliocostalis, this for the longissimus. Again, if we're treating these muscles, especially low, for multifidus, obviously we'll be getting longissimus there as well. Okay. Then to the interosseous sacroiliac ligaments. For the interosseous sacroiliac ligaments, the procedure here, we're going to palpate and identify the spinous processes of L5 and S2 at the level of the PSIS. Needle placement will be at the midpoint between the spinous processes and the ilium with a 45-degree angulation medial to lateral with a backdrop at the SI joint. A cranial needle will be angled slightly inferior and the caudal needle will be angled slightly superior. Unilateral rotation with tenting is recommended with both needles. So as far as dealing with SI joint pain, this approach is very effective at decreasing that localized inflammation in that connective tissue. Again, important once you get the needle in there, do some unilateral rotation and mobilize that connective tissue and get a nice inflammatory response, decreasing that local pain sensation. As with most everything that I do, I will also, after mobilizing the tissue, apply some electrical stim to that area as well. Okay, then for the iliolumbar ligament. For the iliolumbar ligament, we're going to address that from the posterior aspect. Continue to rotate here. And so for the procedure, we're going to palpate for the interspinous space between L4 and L5 and for the iliac crest. We're going to draw a line between the interspinous space closer to the inferior border of the L4 spinous space, laterally to the iliac crest. Needle placement will be at the intersection of the helper line and the iliac crest in a P to A angulation with no backdrop. Okay, then to the posterior sacroiliac ligaments. For the posterior sacroiliac ligaments, we will look at a procedure that will involve palpating for the PSIS. There'll be 3 needle locations at the PSIS. One finger, and it's P to A, 1 finger breadth caudal from the PSIS, also P to A, and then 1 finger breadth cranial and medial, which will be PA slightly lateral angulation. Okay, then we'll deal with the sacrospinous ligament. Again, if we needled Coccygeus, we'll have needled that. So you'll find the approach is basically
for the sacrospinous ligament. The position will be prone. The needle length is going to be 1.5 up to 3 centimeters. The backdrop will be none, and the precautions here is the nerve to levator ani and the rectum. The procedure, we're going to palpate for the sacral horn at the sacrococcygeal junction. We're going to move 1 finger breadth lateral to the sacral horn, which will be the needle placement with a posterior to anterior angulation with a depth no greater than 2 centimeters.
Okay, we'll move from there to the sacral interspinous ligaments. We'll do the sacral interspinous ligaments and then the sacral supraspinous ligaments. Let's look at both of those back to back.
For the sacral interspinous ligaments, we will take a little closer look here. The position here will be in the prone position. Needle length is going to be 1.5 up to 3 centimeters in depth with a backdrop down to the sacrum. We're going to palpate for the sacral spinous processes. And needle placement will be about 1/2 of a finger breadth lateral to the spinous process. And we're going to needle with an angulation posterior to anterior with the sacrum as the backdrop.
Sacral interspinous ligaments. Okay, and then the sacral supraspinous ligaments.
For the sacral supraspinous ligament, zoom in on that structure right there. Here, position, the patient will be in the prone position. Needle length is 1.5 to 3 centimeters. Backdrop directly down to the sacrum. And the procedure here will palpate for the spinous process. Needle placement will be between the spinous process and a posterior to anterior angulation with the sacrum as a backdrop.
That's just purely a midline incision down to the sacrum. All right, so let's move on now to our regional or diagnosis-specific protocols. We'll cover, again, some of this we've already covered in advanced thoracic. Our TL junction, lumbosacral junction. We'll look at sacroiliitis, lumbosacral pelvic junction, sciatica, Piriformis Syndrome, pelvic floor, and it's not listed there, but we'll also cover coccydynia. Okay, so again, good information for you to have. Let's move on down to the video for these.
The protocol for dry needling the thoracolumbar region. Here the patient will be in the prone position. Our primary locations will be multifidus, longissimus thoracis, and iliocostalis thoracis. These can all be accomplished by 2 separate needle placements at each spinal segment, at each segmental level. And which segmental level is just determined on patient symptomology. We move to our secondary locations, and here we'll look at latissimus and the lower trapezius. So coming more to that TL junction right there of the lower traps, and latissimus, big broad muscles that contribute to that TL junction. And then finally moving down to our tertiary locations, and I will move to our location here. All right, so as we move, I'm going to look at 2 different sides. Our obliques, internal and external obliques, and then transverses abdominis. Definitely contributors to issues related to TL junction. And then further, and I've gone a little bit deeper here, we'll look at quadratus lumborum and the psoas major. One could say Iliacus may treat them similarly, but those are the structures identified, and we would look at treating for pain in the TL junction.
Okay, so the regional protocol for the TL, or the thoracolumbar junction. Here, the dry needling protocol, patient's going to be in the prone position. And this is going to be any of those pain patterns that you see from middle to lower thoracic spine all the way down to, let's say, the level of the iliac crest. So very frequently, and when we do treat quote-unquote back pain, we are going to be dealing with more of a TL junction, especially if it comes up into that lumbar spine towards the thoracic junction. Here, our primary dry needle locations are going to be the multifidus, the longissimus, and iliocostalis. Our secondary locations, we're going to go ahead and get latissimus and the lower trapezius. And then for our tertiary locations, we'll hit transversus abdominis, internal, external obliques, the serratus posterior, superior, QL, and psoas major. So let me move this out of the way. Let's bring up our fella here. All right, so first thing we're going to look at, our primary locations will be multifidus. Let me bring up my pen. 3D black. So multifidus. Let's say we wanted to catch, what we know here is L4, 3, 2, 1. Let's say we wanted to needle. Let's zoom in a little bit here. So again, we know 5, 4, 3, 2, 1, the base terminal end of the trapezius. Let's catch our tool again. So 3D. Again, we want to catch multifidus, so we'll come up. Let's come up a segment above. So 1 finger breadth lateral. Okay, we'll do above, and let me change that to black. That's much easier to see. Okay, we are 3D there. Wonderful. So there's multifidus at T12. We'll drop down a level and catch T1. We can take that, or L1, and we can take that all the way down segmentally as we need to. For our longissimus and thoracis, longissimus will be needling as it sits right here. We'll needle through that in the lumbar spine. As we get into the thoracic, it's going to veer a little bit lateral, so we'll have to make a different approach. But here, we should be getting into that. For our iliocostalis, then we're going to have to come from this lateral position, and here our needle will be oriented from lateral to medial, fairly superficial, so we don't get too deep, but still catch all of the fibers of the iliocostalis here. So that's our primary locations. Our secondary locations, let me clear our business there, is going to be latissimus and the lower trapezius, lower traps. We will just simply catch those. Let me get my pen. The lower traps we can catch right here. We'll just grab those with a pincher grip, lumbrical grip possibly, and then thread across this direction. And then for, that's lower trap for latissimus, we're just going to put our hand into that bulk of the muscle in the axilla, and in about this location we will needle away from midline, from medial to lateral, making sure that we don't get into that rib cage. So let's clear that. We'll get to our tertiary location, and here, different locations to do the transverses abdominis, the obliques. So on those, we can actually, one of the easiest ways to get those is with your patient in the side lying position. We can use a pincer grip, and pulling out my pen again, we can pinch those muscle fibers together, and then in the side lying position again, we can needle. It's hard to see this in a three-dimensional view, three-dimensional and a two-dimensional view,
but we'll needle through that. We'll thread through that tissue from a posterior to anterior, or if we happen to be on the anterior side, anterior to posterior, just making sure that it's in a tangent to the body as well. We don't want to orient that needle into the visceral compartment. And so there we can catch transversus abdominis, internal, external obliques. So we move from there, we want to look at the fibers of the serratus posterior inferior. And again, we can see the border of that muscle group right here. So anywhere in this vicinity, we can needle. Fairly superficial, probably less than between 2 and 3 centimeters as far as the depth there. And then lastly, we can go after, let me clear those. So lastly, we can come after QL and psoas. So one of the easier ways, let me hide there. I want you to show you the QL. So here is QL. So you can see the orientation of the fibers of QL. If we take this lateralmost border of Iliocostalis and move further onto the iliac crest, in that window is where we can definitely have our best impact on QL. Now, if I hide that a little bit deeper, then we can see the fibers of psoas. So the way to have a good needle placement here is at the lateral piece of Iliocostalis, just a finger breadth or so further lateral. We'll needle posterior to anterior with some decent depth to make sure that we penetrate into psoas major. It can also be done from the sideline position, but I like and I prefer to take QL and psoas right here, posterior to anterior. And that would comprise our needling protocol for the thoracolumbar junction.
Okay, so let's move from the TL junction down to the lumbosacral junction. And as we move through the remainder of these lumbar, TL, LS, LSP protocols, you're going to see a lot of them merge together. So partly we go through individual ligaments, individual muscles to treat those. But so often, especially when we get into areas around the spine, it's not one individual thing that we have to deal with. It's the entire movement system. It's the whole neuromuscular response. So for the LS junction, let's come down here and look at that.
In the dry needling protocol for the lumbosacral junction, initially, patient will be in the prone position, and we'll look at our primary dry needling locations. Here we'll have the multifidus, the iliocostalis lumborum, the longissimus lumborum, the Psis, and the sacroiliac joint. For our secondary locations, look a little bit deeper. I don't have this exposed right here, but we'll look at the quadratus lumborum and the psoas major, and then finally down to our tertiary locations. Let me come back out just a little bit here. We'll look at the dry needling for the Gluteus Maximus, medius, and Piriformis. Minimus is a little bit further lateral, but it could be included as well.
First, for our primary locations, let me grab my pen. So first thing we would go after would be our multifidus, iliocostalis, longissimus, the Psis, and then the SI protocol. So if we go after multifidus, longissimus, iliocostalis, first thing we're going to do is, let's see, we'll come up to about L3, come across 1 finger breadth away from the spinous process. Let me zoom in just a little bit here so we see everything that's going on. All right, grab that pen back. Okay, so here we'll catch our multifidus and our longissimus. we'll take that threading approach coming across for our Iliocostalis. Then we will look at our Psis, which we'll find sitting right here. Again, that's just going to be a pec down to periosteum. And then our SI protocol, which in this case I would probably just take 2 needles angled this way and that way to meet at the depth, the base there of the SI joint. Let me put those back. Let me take that last one off. Okay, so our secondary would be our QL and psoas major. And if you recall, to get QL psoas major, we're going to take that outer border of Iliocostalis. We're going to come up a couple finger breadths, and we're going to needle here, going into posterior, anterior direction. And then our tertiary locations for the lumbosacral junction would be glute max, glute med, and piriformis. And so max, again, we find the lateralmost apex of the greater trochanter, the Psis. We'll needle here for glute max. And then for med, we're going to follow TFL up to iliac crest. We're going to come over about 3 finger breadths and down about 2 to catch it right there. For piriformis, we've got 2 options, most commonly needled right out here at its insertion, but again, it can be needled off of the lateral sacral border itself. Just more caution there for the sciatic nerve. And so that would be the needle placement locations for the lumbosacral junction.
Okay, from there, we'll move into sacroiliitis. And again, like I mentioned, if you look at the diagram here, you're going to see a lot of these things start to look very similar. But for sacroiliitis,
The dry needling protocol for sacroiliitis, our primary dry needling locations will be up in the lumbar spine. There we'll look at multifidus in the longissimus and iliocostalis lumborum. Our secondary locations will drop a little further distally. Here we will dry needle into the interosseous sacroiliac ligament and the posterior sacroiliac ligament. So some of these much deeper structures here. And then finally, third, the iliolumbar ligament, the sacral interspinous ligaments, and the supraspinous ligaments.
Like our primary locations, again, are going to be multifidus, longissimus, and iliocostalis. Here I'm probably going to try to stay at L4, L5 if possible. Maybe I do both. So here we see, let's see if I can rotate a little bit. Zoom in there. So here we see our spinous processes, and we are going to, so here is L5. So what we will do, let me grab my pen. All right. So we'll come to L5, 1 finger breadth lateral there. So there's multifidus and our longissimus. Iliocostalis is going to be very difficult in this area, so I'll come up to L4. And again, we're going to just needle across for iliocostalis, headed toward the base of the spinous process, but we're not going to have a backdrop there. And so our secondary locations would be the interosseous sacroiliac ligament and the posterior sacroiliac ligament. So we'll come down. So those will be sitting, and here you can see that I've got the thoracolumbar fascia removed on this right side. So here we would catch right just adjacent to the spinous process on the sacrum, and then we'll also want to catch through the interosseous sacroiliac ligament itself. And then our tertiary locations would be...
So I'm going to correct that in just a moment. That's the supraspinous sacral ligament. I'll correct that in just a moment.
Iliolumbar ligament, which we'll find right at this junction. So we'll drop down. So right as the iliac crest is starting to make its descent from the superior aspect is where we'll needle that.
the sacral interspinous ligaments and the sacral supraspinous ligaments. Actually, these are sacral interspinous and supraspinous. Our interosseous sacroiliac and posterior sacroiliac are going to be, and it's underneath Gluteus Maximus here, but it's going to be just distal to Psis. Going to be just a little further distal, and then we'll be here as well. So a little three-point spot right there. For sacroiliitis, definitely you do want to make sure that you add into that a deep, so that this one can be directed. I'm going to just change. This would be more cranially as far as trying to get into the depth. So it's a twofer. You're going to get the ligament, but then you're going to try to get very deep in there as well. Then you can come up a little bit higher and needle in this direction. Again, these two for SI joint and sacroiliitis, you want to get in there, do some unilateral rotation, wind that collagen around that needle, then you can pull the needle back and forth to help mobilize that tissue. And that's where we'll see a lot of our pain relief. And so that's what it looks like for sacroiliitis.
Okay, moving on from sacroiliitis to the Lsp junction.
The protocol for the lumbosacral pelvic junction, the Lsp junction, very similar to the lumbosacral junction, a few more needle locations to encompass a little bit more of the pelvic girdle itself. The primary needle locations will be that lumbosacral junction protocol. So all those needle points from that initial protocol. Secondarily, we'll look at adding on to this the protocol for sacroiliitis, so a little bit more in depth into the sacroiliac joint. And then finally, for the tertiary locations, the entire pelvic rotator cuff dry needling location, which will include glute max min, as well as TFL, piriformis, and then all of the rotators down to quadratus femoris.
Lumbosacropelvic junction. So basically we're going to have our primary locations, those of the lumbosacral junction, which basically are still represented through what we did previously. We'll add into that our sacroiliitis, which is basically adding these 3 points right here in the SI joint itself. And then finally we're going to add in for the lumbosacral, the pelvic part of the lumbosacropelvic protocol is our pelvic rotator cuff. And so again, what that's going to look like is we're going to add in glute max, which again is going to be here. We're going to add glute med. We're going to add glute min. So this will just be going lateral to medial. Here going down to the ilium for depth. We'll also we'll go through the TFL. If we choose, we can thread TFL from posterior to anterior down to the table. And then lastly, well, not lastly, we'll get piriformis. And then lastly, we'll get the deep hip rotators, which would be this 1, 2, 3, 4. This is that redirected method where we get basically pecking into those small fibers of those deep hip rotators. So this is what it looks like for the Lsp junction.
Okay, from the Lsp junction, we'll move on to, quote, sciatica. And with sciatica, I'm basically just referring to any of that centralized low back pain that radiates laterally out towards the greater trach.
And for the dry needling protocol for, in quotes, sciatica, our primary locations will be the pelvic rotator cuff. Again, here we're looking at the 3 gluteal muscles, TFL, piriformis, and then the deep rotators. Our secondary needling locations, here we will include both medial and lateral aspect of piriformis, and then finally we'll come back and include everything in the sacroiliac joint itself, that sacroiliitis dry needling protocol itself.
Our primary location is going to be our pelvic rotator cuff, secondary, our piriformis, and then finally our tertiary will be our SI joint protocol. So for our pelvic rotator cuff, we'll start, I got my pen again, and I've got Gluteus Maximus faded, so greater troch over to Psis. We'll come here for glute max. We're going to come up, over, and then drop for glute med. TFL and glute min, again, midpoint between iliac crest and the greater troch, just needling lateral to medial for glute min, and we can thread toward the table in that same location for TFL. And then for our secondary, well, I didn't add it in here, we will come in to needle piriformis as well, and then we're going to have this coming on down. It's 1, 2, 3, 4 down the road to get all of the muscles of those hip rotators. Okay, so for this, we can also, for our secondary location, piriformis, we've got it laterally. We can also come off of this sacral, lateral sacral border. Again, we use our needle to find the depth on that border. Then we move 1 finger breadth laterally and then advance it 1 more centimeter to land into the medial fibers of piriformis. Again, caution here, because the sciatic nerve definitely runs right behind or anterior to piriformis. And then lastly, would get to all of the ligamentous piece of, for the SIJ, onto, on the sacral, the midline points, we'll have one on the PSIS inferior to that, and medial to that. We'll come up, we'll also catch QL here. And so for our sciatica, that is, it almost looks like kind of a shotgun approach, and it kind of is, except we're definitely trying to target specific things that can be the cause of some of these sciatic, these radiating type symptoms. So that's it for sciatica.
Okay, and from sciatica, let's move on to Piriformis Syndrome. Again, you're going to see a lot of repetition of these locations.
Dry needling for the Piriformis Syndrome. Our primary locations will be the lateral and the medial aspect of piriformis, 2 different dry needling locations. We'll look secondarily at the pelvic rotator cuff itself. So here we'll look at glute max, med, min, TFL, and the deep rotators of the hip down to Quadratus Femoris. And then finally, for our tertiary locations, we will include dry needling for the greater trochanteric bursitis protocol, which on that lateral aspect, and then the sciatic bursa of Gluteus Maximus, right on the ischial tuberosity.
This starts to be almost redundant, but our primary locations here will be our lateral and medial piriformis. So let me get that in play. All right. So for the piriformis, again, we're going to find superiormost aspect of the greater troch. We're going to move over 2 finger breadths and that frontal plane for the lateral piece of piriformis. For the medial, again, we're going to find the lateral sacral border. We're going to use a needle and we're going to just peck down right here to find the depth till we get to the sacrum. Once we find that, we're just going to notice our depth on our needle itself. We're going to move laterally a finger breadth away from that sacral border, and we're going to advance it an additional centimeter to get into the medial fibers of piriformis. After that, we're going to go ahead and throw back in our pelvic rotator cuff. We can catch our our needle locations for the rotators, and then lastly we can go after, which we'll get to this when we get to the hip, our greater troch bursitis and our sciatic bursa of Gluteus Maximus. So we'll catch Again, we'll cover this a little bit later. The sciatic burst of Gluteus Maximus sitting right there. Again, we'll cover these last three whenever we get to the hip. But for Piriformis, everything that could be causing some compression on that sciatic nerve as it advances, these are what we're needling to address that piece itself.
Okay, from there, let's look at pelvic floor. And here, I reference the pelvic floor not in a true women's health or issue along that line, but in so much as it relates to low back pain. Frequently, your pelvic floor can be involved with pieces of low back pain, so we want to include that treatment for that.
For the pelvic floor protocol, this is a protocol geared more towards lumbo-pelvic pain, not specifically to the pelvic floor as it relates to pelvic pain, incontinence, things of that nature. So here we'll address three primary structures, muscles. One is the Coccygeus, coming off of the Sacrococcygeal Junction. Our second will be the Iliocostalius, which will be, we'll identify that off the tip of the coccyx itself. And then lastly, we'll come up a little bit more proximally and look at Piriformis. Again, just a much more distal treatment approach for lumbo pelvic pain. For the pelvic floor as a whole, we'll look at an entirely a different protocol for that approach.
Include this in the lumbar spine. This is definitely not the full approach to dealing with pelvic floor dysfunction, but as it relates to the low back, this protocol can be very effective for people who've identified, or you as a clinician have identified, that the pelvic floor musculature is our target of what we're having problems with. So let me rotate this just a little bit. And I'm going to clear some stuff here. Let me hide Max. And let me hide that. Maybe I'll just fade it. Now let me go ahead and hide that and then fade the sacrospinous ligament. So as you can see, really what we're dealing with for the pelvic floor, we're just going to deal with the Iliocostalis, the Coccygeus, and Piriformis. And so with those, let me bring my pen back. So for Piriformis, we've kind of targeted how we're going to do that. We're going to come off the greater troch, up 1 over 2. We can catch it laterally. We can also catch it off the sacral border. Again, we find our depth on the bony sacrum itself, move 1 finger breadth lateral to that border, and then drop an additional centimeter. If we want to go target the Coccygeus, basically here we're going to find that sacrococcygeal junction. So you have to talk with your patient about what you're doing, without a doubt. In a similar approach, we're going to find our target depth on the coccyx right here, and then we're going to move 1 finger breadth laterally and drop an additional centimeter into the Coccygeus itself. We're going to use that same approach. We're going to go about a finger breadth lateral from the tip of the Coccygeus, and we're going to land into the Iliocostalis. Here we're going to use our needle for Coccygeus as our reference point to needle into the Iliocostalis. Again, there's a lot of tissue underlying, or a lot of content inside the body cavity, so we want to be cautious. We would rather be short than too long in this case. But really good responses out of pain here in this pelvic floor musculature just by these three: Piriformis, Coccygeus, and then the Iliocostalis.
All right, so from there, our next will be coccydynia. Again, very similar to what we have already seen with the pelvic floor.
The pain in and around that coccyx
region. Again, we can deal with that through the pelvic floor specifically, but as far as a regional protocol, let's look at primary location. Again, it's going to be the Coccygeus and the Iliocostalius. So again, we'll find that coccygeal, that sacrococcygeal junction to find where we're going to needle here into the coccygeus. We're going to find the tip of the coccyx. Again, moving a finger breadth lateral for Iliocostalius. Our secondary location is going to be Piriformis. Catch right here. We can also catch here if we're comfortable there, and then it's overlaid. We don't. It's hidden from this view, but Gluteus Maximus would then be right here, which is going to be midpoint between the greater trochanter and the Psis. And then our tertiary is going to be our superior gemellus and the obturator internus. And those we can catch. I mean, we're here. We can go ahead and catch all 4 of those here. So those are all the muscles that we can do with our coccygenia. Obviously, you can do more if you want, but that should be the bulk of what will be effective in treating coccydynia.
Okay, so from here, we're going to move on to our, no, there's one more, just a general approach for peripheral neuropathy. I've been using this approach for a number of years. We get really good response from it. Ultimately, dealing with peripheral neuropathy is a lot to do with diet, activity, exercise. So if your patient will make those changes, this approach has an even better chance of being sustained. But here is how we look at this approach. So what I'm going to demonstrate in just a moment is our primary locations and our secondary locations. Our tertiary, if we choose, we can come up into the thigh itself to look more closely at the nerves up at the thigh, but traditionally we're just going to treat down lower. So let's take a look at that.
The dry needling protocol for peripheral neuropathy will basically use our superficial and deep sensory nerves as a target for trying to decrease symptoms related to peripheral neuropathy, hopefully stimulate the nerve function. So our primary locations distally in the lower limb would be the common fibular nerve, the superficial fibular nerve deep here, and then the superficial fibular nerve as well here on this lateral aspect. We'll move to our secondary structures. Here we'll go further posterior to the tibial nerve and the sural nerve, and then finally we'll come more proximal into, let me come up here. There we are. Into the lateral femoral cutaneous nerve, the femoral nerve itself, the saphenous nerve, and the obturator nerve.
Dry needling, and it can be pretty effective at managing these symptoms. Again, we're targeting near the nerve area. We're not necessarily trying to needle directly into that nerve, but we want to see if we can't stimulate as many of these nerve fibers as possible. And so let's start with our first needle placement on the medial aspect. Let me come up, grab this pin. All right, so the very first thing is we're going to be at the knee. We're going to be above the joint line at the adductor tubercle. And here we're just going from medial to lateral. So we're just going to come right in here for the first. For the second, we're going to be on the tibia at the mid shaft. And here what we're going to do is basically, so it's very thin right here. We're basically going to thread across this the surface of the tibia right here for the medial side.
After that, we're going to move laterally. So let me move my guy here. Okay, so now we're moving over to the lateral side. Let me see if I can. Well, let's start. Let's zoom in just a little bit here. All right, and bring my pen back. So here, our third needle is going to be posterior to the tendon of the bicep femoris. It's going to be 3 finger breadth superior to the joint line. And it's just going to be lateral to medial. So we're going to find that joint line, come up 3 finger breadths through that, and then posterior to this bicep femoris tendon. We're going to go just lateral to medial, and then that's going to give us some of those nerve fibers that are starting to come down here. Now, as the common fibular nerve comes and breaks off, then we're going to go 1 finger breadth distal to the fibular head and needle lateral to medial, posterior to the fibula. So there, we're going to find ourselves right here. Okay. And there are a lot more that we can do up into the thigh. But it's rare that we see our benefit there. Normally, if we hit these 4 locations, then we're going to be in pretty good shape for dealing with peripheral neuropathy. Like I said, we can get much more in depth. If we choose, we can come and follow these nerve paths further distally and try to catch them as they move further into that lower limb. But if we catch them, these 2 on, again, the adductor tubercle across the shaft of the tibia, that'll catch or provide the stimulus that we're looking for on the medial aspect. And for the lateral, again, catching as that tibial nerve is coming down, and then it's turning into the common fibular before it breaks into deep and superficial. We can catch it here as well at the finger breadth distal to the fibular head. That's for peripheral neuropathy.
Okay, so let's move from our diagnosis-specific protocols into our perineural protocols. We've got 3, we've got 5. Really, it's we're going to lump superior and medial colonial nerves together. Then we'll look at the inferior colonial. Then we'll look at the lateral and anterior cutaneous iliohypogastric nerve. So first, let's look at our colonial, superior and medial colonial nerves.
The dry needling protocol for the superior colonial nerve. It arises from the posterior rami of the first, second, and third lumbar spinal nerves. They innervate the skin of the superior and lateral parts of the buttocks. The superior colonial nerve is occasionally prone to entrapment where they pass through the fascia near the posterior iliac crest, which can cause unilateral low back pain. For the protocol itself, our primary neural location would be for the superior colonial nerve. It's from the Psis to 4 finger breadths along the ilium. Needle length there would be 1.5 centimeters. For our secondary muscular locations, Gluteus Maximus, the longissimus, and multifidus with a needle length of 3 to 5 centimeters. For our tertiary locations would be the gluteals laterally to the greater trochanter. And then finally, our proximal spinal segmental locations would be L1, L2, and L3. The dry needling protocol for the medial cluneal nerves. The medial cluneal nerves arises from the posterior rami of the first, second, and third sacral spinal nerves. They innervate the skin of the posterior part of the buttocks. This branch may become restricted in its osteofibrous tunnel against the iliac crest, just as osteofibrous tunnels affect other nerves, such as in carpal tunnel syndrome. The clinical symptoms include pain at the low back, which may radiate to the ipsilateral leg. The clinical signs include marked tenderness at the iliac crest rim just above the dimple at the buttock and decreased touch sensation of the buttock just below the iliac crest. For the protocol itself, our primary locations would be the medial cluneal nerve, the middle 1/3 along a helper's line from the PSIS and the sacral horn, and then also the superior cluneal nerves from the PSIS to forefinger breadths along the ilium. Needle length here would be 1.5 centimeters. Our secondary muscular locations would be Gluteus Maximus, the Longissimus, and the Multifidus. Needle length would be 3 to 5 centimeters. Our tertiary locations would be the gluteals laterally to the greater trochanter. And then finally, our proximal spinal segmental locations would be S1, S2, and S3.
We'll look at these at the same time, since it's very similar between both. On the right-hand side of this body, you can see I've got the Gluteus Maximus removed. On the left, you can see I've got the thoracolumbar fascia removed. So basically, these cluneal nerves, especially the superior, which are right here, come across through that thoracolumbar fascia over the iliac crest into the superior most aspect of that surface of the gluteals. The medial just sit further below the between the PSIS and down to the sacrococcygeal junction. So when we're going to needle these, and I'm going to do that on this side over here. See if I can zoom back out. There we go. Grab my pen. We're going to, for the primary, we're going to look at our medial cluneal nerve. It's going to be the middle 1/3 along helper's line from the PSIS and the sacral horn. The superior cluneal nerves from the PSIS to forefinger breadths along the ilium. Our needle length is only going to be about 1.5 centimeters. So we find our sacral horn. Again, you have to talk to your patient about what you're doing. So for medial, we're just going to be right in this area. You can do several, or you can just do a single. And that's for medial. For superior, you're going to be from the PSIS along forefinger breadths along the ilium here. If we find our PSIS, going to move that forefinger breadths up, and then we're just going to come in this area. 1 centimeter if you feel like you need to go a little bit further depth. Again, we're talking about encroachment or impingement or entrapment, where these nerves exit the thoracolumbar fascia coming over. You can see this, police officers, people that have to wear a heavy belt with lots of tools can have compression of those nerves there as well. So for the superior and the medial cluneal nerves, the needle location is there between PSIS and the sacral horn, and then between the PSIS and about forefinger breadths along that iliac crest. Okay, from there we'll move on to the inferior cluneal nerves.
The dry needling protocol for the inferior cluneal nerves. The inferior cluneal nerve arises from the posterior femoral cutaneous nerve and supplies the posterior thigh as well as the distal buttocks. Its segmental location is S2 and S3. The inferior cluneal nerves, also called the gluteal branches of the posterior femoral cutaneous nerve, innervates the skin of the lower part of the buttocks. They arise as branches, the posterior cutaneous nerve of the thigh. Our primary neural location will be the junction of the medial and lateral hamstrings at the inferior aspect of the gluteus maximus. Also at the inferior medial aspect of the gluteus medius. Needle length here is 1.5 to 3 centimeters. And then our proximal spinal segmental location will be at S2 and S3.
Inferior cluneal nerves. Again, I've got gluteus maximus removed on the right. The inferior cluneal nerves are the branches that you see. Let's see if I can get close. Right here. So if we follow their path, you can see that they're coming off
and very close to the hamstrings as they come onto the tissue of Gluteus Maximus. So if we're feeling like it'd be appropriate, if maybe there's some entrapment that's taking place there, probably not very likely, but if it is, if there's some altered sensation, we might try this approach. So here, our dry needling protocol would be, bring my pen, at the junction of the medial lateral hamstrings at the inferior aspect of Gluteus Maximus. So here we want to just get right into the business right here. Oh, didn't get my pen all the way. There we go. So right there, and then we want to also get into the inferior medial aspect of Gluteus Maximus. So we're going to catch some of that right here, but we may also want to needle a little bit into the muscle itself, right in that same general location. Again, clinically, we're not going to see this that often, but in the event that we do suspect some sort of an impingement on that inferior colonial nerve, this would be the way to address that.
From there, let's move on to the lateral cutaneous iliohypogastric nerve.
The protocol for the lateral cutaneous iliohypogastric nerve. The nerve supplies the skin of the gluteal region. The lateral cutaneous branch, or the iliac branch, pierces the internal and external oblique muscles immediately above the iliac crest and is distributed to the skin of the gluteal region behind the lateral cutaneous branch of the subcostal nerve. The size of this branch bears an inverse proportion to that of the lateral cutaneous branch of the subcostal nerve. When harvesting bone from the anterior iliac crest, the lateral cutaneous branch of the iliohypogastric nerve is most likely to be injured. For the dry needling protocol, patient will be in the sideline or possibly prone position. Target structure, again, lateral cutaneous iliohypogastric nerve. Our primary location is going to be along the iliac crest from the location of the posterior IT band attachment, posteriorly 2 to 3 finger breadths further posterior. Knee length here will be 1.5 up to 3 centimeters. Our secondary muscular locations, again, internal, external obliques, the transversus abdominis, and tensor fascia lata. Knee length there would be 3 centimeters. Finally, our proximal spinal segmental locations would be L1.
Branch of the iliohypogastric nerve. What we'll do, our primary location, our neural locations, we're going to be along the iliac crest from the location of the posterior IT band attachment posteriorly 2 to 3 finger breadths further posteriorly. And here, so we'll come up 2 to 3 finger breadths further lateral, and then we'll needle up. Let me grab my pen. Helps to draw if I have my pen. And so then our first needle will be right here. Secondary, our muscular locations, we're going to be the external oblique, internal oblique, the transversus abdominis, and this is one, if you remember, we'll find the iliac crest, the rib, and then midway between them, we're going to thread through those muscles right there. We're here, we've obviously, this nerve comes down, we want to go ahead and also we're going to needle or thread through the TFL. So we'll thread this direction, and honestly, it depends on, are they sideline, are they prone, supine, how we get to this. Honestly, the easiest way is in the sideline position, so that you can needle and have all of that sky side where you want it. And so if we also wanted to, we could come up to L1 for our proximal spinal segmental locations. So we come up just a little bit higher and then needle there at that spinal segment. And that is the lateral cutaneous iliohypogastric nerve.
And then our last nerve that we're going to look at will be the anterior cutaneous iliohypogastric nerve.
For the anterior cutaneous iliohypogastric nerve. The anterior cutaneous branch of the iliohypogastric nerve passes along the crest of the ilium and it enters the internal oblique muscle at the level of the anterior superior spine of the ilium and runs through the aponeurosis of the external oblique muscle. These branches supply the abdominal area beneath the navel, and its branch is L1. The anterior cutaneous branch, or the hypogastric branch, continues onward between the abdominal internal oblique and the transverse muscles. It then pierces the internal oblique, becomes cutaneous by perforating the aponeurosis of the external oblique about 2.5 centimeters above the subcutaneous inguinal ring, and is distributed to the skin of the hypogastric region. For the dry needling protocol, the patient will be in the supine or the side lying position, and again our target structure is the anterior cutaneous iliohypogastric nerve. Our primary dry needling location along the iliac crest from the location of the anterior IT band attachment anteriorly 2 to 3 finger breadths further anterior. Here, needle length will be 1.5 to 3 centimeters. Our secondary muscular locations will be the internal and external oblique, the transverses abdominis. Needle length here will be 3 centimeters, and finally, our proximal spinal segmental location will be L1.
Iliohypogastric nerve. So I'm going to move this around a little bit. So we just covered, I've removed the internal, external obliques. So what we're seeing is the nerves on the rib cage laying against transversus abdominis. So the nerve in pink is our anterior cutaneous iliohypogastric. We had just needled posterior cutaneous, which sits right here. So what we're going to do for anterior cutaneous, so its distribution, as you can see, is this lower, just above the inguinal ligament, this lower abdominal. Again, people wearing tight belts could be more suspect for issues here. But for here, our primary location, it's going to be along the iliac crest from the location of the anterior IT band attachment. Here we're going to go anteriorly 2 to 3 finger breadths anterior. So for posterior, we went followed IT band up. We went posterior 2 finger breadths. Here we're going to come anterior 2 to 3 finger breadths. So grab my pen. So we'll follow the IT band up, and then we're going to move forward into this area. Our secondary muscular locations, again, we're going to have external, internal obliques, transversus abdominis. So again, we're going to find this midpoint, and then we're going to thread through these muscles right here. We're going to pinch them up and needle through those. Our secondary, our muscular locations are those. If we want to, we can come up again. I don't have it listed on this, but we could definitely, again, needle through transversus, TFL if we wanted. Odds are we would have a little anterior and posterior developing at the same time, since they are off of the same nerve root, which is L1, which would be our final segmental location. If we wanted, we could come up there to L1 and needle for our segmental location. And that is the anterior cutaneous iliohypogastric nerve.
All right, so our postmodule assignment, we've gone through all of the muscles, tendons, ligaments, perineural protocols, the diagnosis, specific protocols. So for the postmodule assignment, you're going to see some similarity. Again, what the difference here, I want you to select an active patient that you're treating and perform the 3KS, 3D kinetic screen, that includes the following: the cervical linear motion, diagonal rotation, trunk rotation, and then lumbar linear and diagonal rotation. We're going to do 5 reps on each side. Submit a video only if you have permission from your patient, as defined by your practice, and then submit a brief description of what your analysis of the 3KS screen tells you. And then, given the limitations that you identified, what structures would you target for dry needling? After dry needling, repeat the 3KS and describe any change that you noted. So that concludes module number 7. Up next will be module number 8, if I'm not mistaken. From here, we're headed up to the shoulder. So get that assignment submitted if you're taking this for CCU credit and to attend Lab 1 and 2. Next we'll see you for Module 8 and look forward to discussing a little bit about the shoulder.